Hi, my name is Trenton Chang. I'm a PhD student at the University of Michigan. This work was done in collaboration with Dr. Michael Schoding and my advisor, Jenna Weens. To appreciate the potential impact of disparate censorship, consider the following example. We want to apply cardiac stress tests to a patient population in order to diagnose heart attacks. In this example, we'll focus on two groups of patients, male patients in blue and female patients in red. At admission, we don't know for sure if any of these patients are having a heart attack. If we had infinite resources and perfect tests, we'd just test everyone and find out if every patient was having a heart attack. But we live in a world of resource constraints and imperfect tests. Ultimately, whether or not someone receives a test might come down to clinical judgment. Hypothetically, let's say 75% of male patients are given cardiac stress tests, while 25% of female patients are tested. This testing disparity is on the extreme side for illustration, but testing disparities do exist in a variety of diagnostic and laboratory tests in clinical care today. Let's replace the question marks for tested patients with their actual test results shown here. Later, let's say we want to train a machine learning model to predict the risk of heart attack. As labels, we want to use cardiac stress test results. As training data, let's pull some covariates from the electronic health record. Let's call these X1 and X2. First, we'll plot the covariate values for tested patients. If our entire dataset looked like this, then training a model on these patients is pretty straightforward. Now, let's plot the covariates for untested patients. You'll notice that the untested patients don't have labels, so how do we train a model with them? In order to help these models generalize to a broader range of patients, machine learning researchers have previously marked such patients as negative. If we train a model on this data, we might get a decision boundary that looks like the red dotted line. But remember, we assumed that untested patients were negative, that their covariates didn't indicate a heart attack. What if this assumption is wrong? What if these female patients were actually having a heart attack? In this case, we'd say that female patients are undertested. This means that at equivalent levels of risk, for instance, this hypothetical high-risk bracket, female patients are less likely to receive the relevant cardiac test than male patients. So our risk stratification model might end up underestimating risk for certain patient groups. Now, let's think about how our model might behave in practice. Let's say we use this model to triage patients for testing, and we see this female patient, who is from the undertested group, presenting similarly to previously untested high-risk patients. In that case, the model is going to predict that the patient is low risk, but this prediction is wrong. Moreover, this patient won't get tested, further amplifying this source of bias. In summary, different patient groups might get tested at different rates. When we assume that untested patients are negative, patient risk stratification models may learn to encode testing disparities. This can lead to risk underestimates for certain patient groups, and such biased predictions can reinforce decisions to not test patients with underestimated risk, perpetuating this problem. So when do disparate censorship and undertesting lead to biased models? And what should we do about it? To find out the answers and more, come visit our poster.